أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين رب زدني علما رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Dear friends, fellows, students, and those who are interested, very few are interested in learning the art of the clinical radiology, although they are very less in amount, but I hope who are interested will inshallah gain knowledge and they will apply in their practical life, and they will not dependent on the report of the radiologist, because you have seen the case, you have advised the exercise, you are responsible for the outcome of this patient. So I have done up till now about 9 cases, or 8 or 9, because number which I put was wrong previously. So I will start with what is I call the reporting exercise number 8, which is actually 9, because of the number put before was wrong. That is, I have called this 8B case. An interesting case, a 50 years old patient. The patient is the farmer who was a smoker and had taken 2 months ATT for hemoptysis and fever. In our country, actually, when we diagnose hemoptysis and fever, and in the end we concluded as pulmonary cox, because pulmonary cox here in Pakistan means very, very disturbing to the family and to the person himself. He will not go to the work, he will depend on the others, and in this session, what we say that dependency is started and ends in the beggary. Sometimes the patient will beg. Actually, there is no need of it. That is why we put hemoptysis and fever. Said it is prolonged fever. You have to take the prolonged course of the drugs for 4 months or 6 months accordingly, and you will find this is the correct way to do it. And there are definitely NGOs which are helping us. The patient, he was non-compliant because of the adverse effects. What will happen here in the pharmacy, that they give the drugs and they tell the patient that take these drugs early in the morning before meals. There are 8 or 9 in numbers. The patient usually takes early in the morning in empty stomach. He feels nauseated afterwards and vomited out. That's why he has left it, because of the problems, or the drug itself causing the problems, the ATT call, as far as the ATT is concerned. The first line of management of the ATT are the 4-drug therapy for 2 months, and then 2 or 3 drug therapy for further 4 months. It's difficult for the patient to take this early in the morning. So patient has to be convinced to take it. How he will take. This is not my subject, but I'm just telling you about my experience. It is very difficult. When the consultant will tell him how to take it, then he can understand well that these drugs should be taken for the further period of time, and they will be definitely, because these are the biochemical agents, pharmaceutical agents, and they can cause problems, and the patient has to tolerate these problems. Now he presented with a high grade fever, with the chills and the dry cough since 2 weeks. Presently, dry cough with a high grade fever. In our setting nowadays, dry cough with a fever, high grade fever, first of all you have to exclude two things. Number one is dengue, number two is coronavirus. So he was screened definitely for them, for these diseases, and he was severely anorectic when he was presented and nauseated. According to him, the therapy which was advised by his GP, definitely he was taken the broad spectrum antibiotics and NSAIDs or analgesics, etc. And that is why he is anorectic and nauseated. On examination, the temperature was 101 degree Fahrenheit. The temperature is 100 Fahrenheit. He said that it is high grade. High grade doesn't mean 105. It is more than 103. According to statement of the patient, it is high grade fever. To us, it is not high grade fever. The pulse is 112 per minute. Definitely sinus tachycardia occurs. The pressure was 90 by 56. Seems to be hypotensive because he was not taking properly the fluids and the nutrition. Anemia was positive, dehydration was positive, digital clubbing was positive, generalized non-tender lymphadenopathy, and coarse capitation diffuse in the chest with occasional sonorous rhonchi, high musical notes. There are sibilant rhonchi, which you see in cases of the bronchial asthma. And here is sonorous rhonchi, means the large bronchioles or bronchi are involved in this case. The liver is 4 centimeter and spleen was 3 centimeter below the costal margins. They are palpable, not tender, and they are palpable. Investigation hemoglobin is 8.5, definitely. He is anemic but normochromic, normocytic. It is a chronic anemia of the chronic inflammation. Remember, the anemia of the chronic inflammation will be normochromic, normocytic. The TLC is 7,600, although the DLC shows the neutrophil was 55%, the lymphocytes was increased to 45%. In argon, 35% lymphos are normal. More than this, it means that lymphocytosis is now gaining. So 45% means significant lymphocytosis. ESR 88 millimeter, random blood sugar was 124, and urine RE proteinuria, which is +1, because it is a benign proteinuria because of the fever. Do not confuse with it. X-ray test done and presented to you for the reporting. This is the X-ray test PAV which was presented. The requirements are fulfilled or not. This is the PAV. Yes, it is supraclavicular fossa which are dilated. It is the frontal projection. Although the spine is very visible here, but the spaces are not visible. So it is the PA view, not AP view. Secondly, the patient should be standing in a straight line. So spinous process is here, make a 2 point there and make one line here, and at the sternoclavicular joint, upper part, one line here. There should be 90 degrees on the both sides. It means the patient is in state S plus S plus S. The second S was, he was standing or not. The first rib, second rib, third rib, fourth rib, fifth rib, sixth rib, seventh rib. Yes, he is, standing position, because in the decubitus position or sitting position, the dome will come here, up to the fourth rib. So he was standing. It still means that he has taken deeply inspired, so the lung will expand and hold the breath properly, not expire. How will it? It means that the ribs one counting, second, 30, 4, 5, 6, 7, 8. Enough ribs are counted here. Inspiration is going on, although it is restricted one, and he was not expiring because of the bronchovascular markings are seen here, here, or something like this. Although there are diverse type of obesities are there. These are the bronchovascular markings. It's not expiring film. Then the bony skeleton is concerned. This is the cervical, no problem with the cervical. The medial border of the scapula is definitely on the most little side. Yes, it is. The joints seem to be normal to me, which is seen. The cervical spine or thoracic spine, there is no excessive ribs. About the rib cage is concerned, the first intercostal, second, third, fourth, one, upper border, lower border, upper border, lower border, upper border, and lower border, symmetrical borders. And this is the mid-clavicle line. I measured this here. It is 2 centimeters around, 1.8. So restrictive or narrow spaces are visible. Something going wrong in the lung, which is very near to a disease, a group of diseases which call it restrictive type of lung diseases. We don't know. Further exam, we will report it and then come to the conclusion. The apex will be compared to the other apex, the first intercostal space with the other, the second with the second, the third with the third, fourth with the fourth, fifth with the fifth. The lung fields for the study purpose will be divided by second rib. I put a line, straight line here, transverse line, imaginary line, and then fourth rib, imaginary line. This is right upper, right middle, right lower, left upper, left middle, left lower. There are 6 lung zones. In these 6 lung zones, the normal components are aerograms and the bronchovascular markings, and the proportionate them. Other than this is alien, which means it is maybe a radiobesity, which we are actually facing it here. So all lung fields are involved with the multiple type of opacities. If you see by the hand lens, you can recognize the opacities very well. The parenchyma between the 2 opacities are normal, the bronchovascular marking moving inside it. So multiple opacities are seen. If there are multiple opacities, we divide it accordingly to the size. Just like opacities, 0.5 millimeter less. Miliary opacity is 0.5 to 2 millimeter. 2 to 10 millimeter micronodular, 10 to 20 millimeter the macronodular, mixed micro or macro, and more than 20, they are called cannonball opacities. There are no specific shapes, they are called patchy opacities. Now these terminologies, if you can remember, it will help you in the diagnosis. Now the sizes of these multiple opacities is hardly 1 millimeter, 1.2 millimeter. These are the miliary shadowings bilaterally present in this patient. Miliary shadowings. Because the person was previously treated with the ATT and he was non-compliant, now he is presented with high-grade fevers and other things, and anemic and other markers. All are supporting that the patient has the relapse of it. Now it relapses in a very bad fashion. That is the miliary shadowings, miliary tuberculosis occurs. Actually, miliary tuberculosis is a radiological diagnosis. We have examined the cervical lymphadenopathy, hepatomegaly, splenomegaly, clubbing, all these things showing that it is a systemic in nature. It is called disseminated tuberculosis. Disseminated tuberculosis is the clinical terminology. On the X-ray, we will put it as a miliary shadowing and vice versa. But definitely there are other causes of the miliary shadowing as well. In the end, I will repeat it for the differential diagnosis. The costophrenic angle and the cardiophrenic angle, and the costophrenic angle and the cardiophrenic angle. On both sides, dome of the diaphragm are normal. Trachea is central, yes, slightly deviating here to the right side, but it's normal, 10 degree. 10 degree towards the right is normal. The trachea was normal. Then the lower part of the middle mediastinum, which is called the heart and the membranes, size and then shape. Now size is normal, the shape is the left border, right border, normal, nothing significant. Where the border changes the direction, we put an imaginary line here. So there will be division upper mediastinum and the lower middle mediastinum. The upper part of the middle mediastinum again will be divided for the study purpose into 4 parts. One line here and one line here. The first one is representing the ascending aorta, the second and the third representing the arch of aorta here, aortic knuckle, and the fourth here it is the pulmonary conus, a pulmonary artery shadow, main pulmonary artery. This is, although it is slightly prominent, but it is not dilated, enlarged, I mean to say that. And then we go to the hyla is concerned. This is the hyla, like this. Although the opacity is visible inside it also. This is a C-shaped. If you measure it, it comes 3 to 0.5 centimeter. If you measure this time it comes about 3 centimeters. Normally it is 2.5 centimeters, less than this. The bilateral limb, hylar lymphadenopathy is there, and if you continuous with this, the paratracheal lymph nodes are here. The subcarinal lymph nodes are there, although they are not calcified, you cannot see. So bilateral lymphadenopathy, there is evidence. The upper part and the lower part of the right hilum is going up and going down, masked by these opacities. The conclusion of my all this thing is that his patient who has got the requirement has been done properly, and the positive points which I have collected in this X-ray is there are diverse type of the multiple opacities. I measured it, it comes under 1.2, 1.5, and it is called miliary type of the shadowings. All fields, lung fields are involved. Multiple costophrenic angles are clear, there is more evidence of pleural effusion. This is the most important finding you have. This is the positive finding in this patient. Evidence of the cervical lymphadenopathy is there, this paratracheal lymphadenopathy is there. For the scenario, it was seen that is generalized cervical lymphadenopathy. Now this is the findings, the conclusion is this. After conclusion, you have to go for what? The differential diagnosis. Acute inflammation and the result of acute inflammation. Yes, there is an acute inflammation which is called what is known as bronchopneumonia of many types. There are types of bronchopneumonias. And it will cause these same type of shadowings. Remember this. Transient shadowing for 1 week or 2 weeks and then gone. Even very, very hyperdense type of the miliary shadowing was seen after the post-measles attack of pneumonia. Acute inflammation and the results of acute inflammation, yes, tuberculosis, miliary shadowings, fungal infections can cause these type of problems, yes. And about the tumor and the tumor-like states, the secondaries in the lungs can present like that, yes, it is possible. Allergic condition can present it. It may be positive that extrinsic allergic alveolitis can cause these type of shadowings, leading to the honeycombing afterwards. Pulmonary eosinophilia can cause these type of shadowings. Pneumoconiosis of any type can cause these type of shadowings. All lung fields and global change. Autoimmune diseases, rheumatoid arthritis, SLE, and the systemic sclerosis can cause infiltrations in the lungs and appear as a miliary shadowing. It is possible, although it is 5 to 10% of cases. Parasitic invasions of the lung can cause reaction in the lung, and it can cause the multiple shadowings, and it may be possibility of the miliary type of the presentation. It is possible. Everything is possible. Lastly, but not the least, are the cardiac manifestation, where the pulmonary edema occur in this patient, although this is not the case. If you give the fusimide, the fluids, they are absorbed and it will appear like this. The shadows are multiple because you are giving the diuretic and gradually increasing it. So in cases of the pulmonary edema, the picture of the radiology chest will alter in 2 to 3 days, 2 to 3 days, 2 to 3 days. But there is no history of the any cardiac problem is concerned here in this case. So inference is this, that this patient has most probably the miliary type of the tuberculosis, bracket, disseminated type of tuberculosis. He should be investigated further, sputum AFB for culture and sensitivity, that is important. MDR-TB or extensive MDR-TB. You cannot start therapy without it. Liver function is done first and then started. Isolation is needed here for 15 days at least. And then you go for other investigation, lateral view and HRCTs and all system liver function tests with UCE. All should be done when you start the therapy. Therapy will be given in this case. It should be given not for 6 months, it is more than 6 months. It should be at least 9 months. If it is extensive one, you will go for the 1.5 to 2 years even. Difficult to manage these cases, but if you convince the patient, he will definitely convinced by you. Although this case should be referred to the pulmonologist, because I am internist, I can deal this case well. Why I will refer? I will deal myself. So this is the case of discussion of today. I hope you have enjoyed it. Probably you have understood it. And we will see you again within the next 2 or 3 exercises remaining, which I will report it. And inshallah we will gain knowledge from it. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alameen wa ma alayna illa al balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.